Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hello, everyone. My name is Dr. Deepak Talreja. I'm an interventional cardiologist with Sentara Cardiology Specialists in Norfolk, Virginia, and with the Sentara Norfolk General Hospital. I'm here today to present my case using Aggrastat in an intraprocedural thrombus. The purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with the contemporary use of 2B3A inhibitors. Here are my disclosures. I receive research support from Medtronic and Abiomed, and I'm on the Speakers Bureau for BI Lilly, Kiniksa, Janssen, Pfizer, and BMS. I receive financial support from Medicure for the creation of this video. Here's the patient case. This is a 62-year-old man who developed indigestion-type chest pain with tingling in his fingers on the left side the day prior to admission. He then developed lightheadedness, dyspnea, and diaphoresis with jaw aching that prompted him to present to the emergency room from which he was admitted. His initial ECG showed nonspecific ST changes, there was no ST elevation, and he had an initial normal troponin of 9. Repeat labs, however, showed that his troponin had elevated to 59. His past medical history was relevant for tobacco use. He had a 40-pack-year history, for hypertension, but he had no known previous dyslipidemia or diabetes. With ongoing symptoms and a diagnosis of ACS non-STEMI, he was taken directly to the cardiac catheterization laboratory. Before describing the next steps, as a refresher, Aggrastat, or tirofiban hydrochloride, is a reversible antagonist of fibrinogen that binds to the glycoprotein 2B3A receptor, where it blocks the final common pathway to platelet aggregation. It has a 2-hour half-life, and the platelets return to normal function between 4 to 8 hours after you stop infusing this agent. Aggrastat provides very potent and rapid platelet inhibition and has a very consistent response for patients. Importantly, through its mechanism of action, Aggrastat has the ability to disaggregate an existing thrombus, which neither an anticoagulant like heparin nor a P2Y12 inhibitor can do. There are limitations to what thrombus it can disaggregate. Typically, it's most effective in a fresh thrombus. So back to our clinical case. Here is how we proceeded. The right coronary artery was noted to be occluded with collaterals from the left anterior descending coronary artery. It could not be successfully wired and my colleague suspected that it might be a chronic total occlusion rather than an acute lesion. And ultimately, he elected to put the patient on heparin and tirofiban overnight with combined guideline-driven medical therapy. After this unsuccessful attempt to wire the occluded right coronary artery on day 1, as you see in the attached videos, the patient the next day was evaluated and had recurrent chest pain. When I saw him that day, I elected to take him back to the cardiac catheterization laboratory. As you can see from the image, I saw something very different from what we had seen before. Now, on this shot of the right coronary artery, we can see that it was not a chronic total occlusion, but a thrombotic occlusion, and the infusion of Aggrastat had disaggregated the thrombus, so now the path was clear, and so I was able to go on and successfully perform a PCI on this patient. He underwent PTCA, aspiration thrombectomy, and placement of a drug-eluting stent, as you see in these slides. Because of his heavy thrombus burden, I continued the tirofiban postoperatively for 24 more hours with long-term dual antiplatelet therapy with clopidogrel and aspirin 81 milligrams. In the final picture after stent deployment, you can see that there's still some distal thrombus for which I continued both the Plavix and the tirofiban for an additional 24 hours to further disaggregate the remaining clot. After successful completion of this PCI, his chest pain resolved entirely. He was maintained on dual antiplatelet therapy for 1 year and then transitioned to aspirin only. To this day, he continues guideline-driven medical therapy and lipid-lowering therapy with a successful change in his diet and lifestyle. A subsequent nuclear stress test, now at 5 years, showed no new ischemia and a low normal ejection fraction, and he's clinically done very well. So here are some takeaways from this case. Aggrastat can be used in patients with intraprocedural thrombus. In this case, intraprocedural thrombus occurred distally despite pretreatment with dual antiplatelet therapy. PTCA, aspiration thrombectomy, and the combined use of IV Aggrastat bolus and infusion can help establish successful TIMI-3 flow. Aggrastat use facilitated a successful PCI in this patient who had clear intraprocedural thrombus. Thanks for watching, and if you have any questions, please reach out to the Aggrastat team for more information.